My name is Mitsuru Nagata from Shonan Fujisawa Tokushukai Hospital, Japan. I'd like to thank the editorial board of Endoscopy for the opportunity to introduce our article titled Prospective randomized trial comparing conventional and underwater endoscopic submucosal dissection for superficial colorectal neoplasms. I am the first author of this article. Underwater ESD provides a magnified visual field without halation. Moreover, it offers a natural traction using a water pressure from the endoscope or buoyancy effect. We hypothesized that underwater ESD would expedite submucosal dissection compared with conventional ESD. Therefore, we conducted a randomized controlled trial comparing these two methods. The primary endpoint was dissection speed defined as the specimen area per ESD time. We analyzed the data of 69 and 70 conventional ESD and underwater ESD cases respectively. However, no significant differences were found in median dissection speed between the groups. This result could be attributed to two reasons. First, in the underwater ESD group, the median recovery time after active bleeding tended to be longer with a higher frequency of hemostasis. Second, air bubbles generated mainly by submucosal dissection during underwater ESD repeatedly impair the visual field. Because the coagulation mode generates more air bubbles than the cut mode, there can be a hesitation to apply coagulation mode for submucosal dissection, resulting in insufficient coagulation of vessels. Such an event would increase the frequency of hemostasis in the underwater ESD group. Therefore, it is necessary to overcome visual field impairment due to bleeding or air bubbles during underwater ESD. Most ESD devices and techniques are designed to be used under gas conditions and are not necessarily suitable for underwater conditions. It is necessary to develop devices and techniques that can address the visual field impairments caused by bleeding or air bubbles. Novel solutions for air bubble removal have recently been reported, such as a food with air bubble outlets, continuous low water pressure dissection technique, gas-free saline immersion dissection technique, and automatic water irrigation system. Moreover, the use of gel immersion may facilitate the management of bleeding. However, these solutions need to be validated in further studies. Multiple regression analysis reveals that the suitable position relationship between the region and direction of gravity, non-gravity side for conventional ESD and gravity side for underwater ESD, was independently and positively associated with dissection speed. In clinical practice, endoscopists do not have to perform underwater ESD for the entire procedure. It might be better to use these two methods depending on the position relationship between the region and the direction of gravity, because they can easily switch between the two methods at any moment without requiring special devices. In summary, underwater ESD did not expedite dissection speed in the overall patient population. Conventional ESD and underwater ESD may be complementary in the colorectal depending on the position relationship between the region and direction of gravity. Thank you for your attention.